Well, you guys are all very hardy people. Okay, so I'm going to try to just go through the questions as we've had them. I had some that I gave to Dr. Alvarez. Maybe he could summarize since he's talked about the vaccine issues.
Yeah. Try that again. Okay, perfect. Yeah, so we got a kind of a variety of questions. One was the vaccines are still not 100%. That's a little bit more of the answer to the question. We're still seeing patients who have gotten vaccines that are not necessarily immunosuppressed, who are still getting infected. We showed the curve showing that people that are vaccinated, are still unfortunately dying as well. Colin Powell is probably one of the more famous cases that, occurred a couple of weeks ago. But it reduces the chances of that by a lot. So if you're going to Vegas and you're going to bet on something, I'd bet on somebody who's been vaccinated over somebody who has not been vaccinated. Specifically around sort of an 18-year-old who is not immunosuppressed. So I think this is the issue of having to kind of look at the risks. It's kind of like wearing a mask, in what kind of situations. If you're going to a rave, I wear a mask. If you're out hiking outdoors, I wouldn't wear a mask, and having to kind of see sort of what your risk is. We talked about age, disability, and other factors like this to kind of go through that. The other one was the difference between third dose, fourth dose, booster. So third dose, if you're immunosuppressed over 65, forgetting a third one. But in those situations, then the booster is the third dose. There's no difference really than Moderna with the half dose. And so the idea is, as we kind of keep looking at this and advancing, is that you would just call that third dose, then a third dose and not a booster, and then try and do a fourth dose as the booster later on. Comment around exacerbating symptoms and having relapses, symptoms lasting for 4 months in this case. And yes, we could see sort of the long-lasting effects a lot of times. It's hard to imagine the vaccine lasting that long, but sometimes it can kind of kick up symptoms, especially fatigue and having to kind of break those cycles of some of those symptoms. But most people don't, and most of the symptoms really resolve once the fevers and, kind of the body aches, which tends to last maybe at most a day or two for most everybody. Because they're not causing relapses, we don't tend to see black holes associated with those. And then somebody unfortunately developed a blood clot with the second Moderna shot. And again, should I get a booster? And I think these are the situations where then you start to kind of look at reactions to it in that situation. I think it would be kind of highly debated, between different people will probably give you different advice. I think in those other situations where sometimes then you kind of say, okay, that's enough. A lot of times these clots can be prevented by just exercising afterwards and things like this and being active. But I think in kind of depending on other health issues and things like this, talking to your doctor specifically about those situations become important. And are there any new vaccines? Unfortunately, the 3 vaccines that are available in the US seem to be the 3 vaccines that we're kind of going to get. There's a lot of other vaccines that are being used throughout the world, almost 30 different vaccines that are being used throughout the world. And they all, to some variability, look to be really safe and effective, just having gone through the approvals like they have in the US.
Yeah, Dr. Shaw had a couple.
I just had 2. One was hot flashes and MS, annoying, but is there any change or reason to change hormone decisions because of MS? And the short of that answer is no, not quite yet. There have been a few studies looking at hormonal replacements, in particular in that period of menopause and related to MS. And the most important thing is just to make sure you're not using unopposed estrogen, just because it increases the risk of breast cancers and other female organ cancers. And then the second question was about this term recrudescence that I put up on my slide. It is the same thing as pseudo relapse. I guess I just tend to use that term because I don't like using the word pseudo, just because it implies that it's not as real as it is, but it's the same thing. So interchangeable.
Okay, and there's one follow-on question. It says, could the ratio of 3 to 1 women versus men in MS be because women will report symptoms quicker than men because men may not be concerned with many of the symptoms?
Good question. Maybe. I think that's a hard one to answer.
There is some data around MRI data suggesting that, that there's more lesions in women than men, as far as just blindly looking at that.
Yeah.
There are more objective measures.
But also women go to doctors more than men in general. Now it could be that they have more conditions, they live longer, they have a variety of other things. They have pregnancy issues that men don't have. But it could be is the point.
Not that we're sexist or anything. There's a question about, are there any new advances from research on medications for those over age 70? John, do you have a comment about that?
Unfortunately, same comment as before, actually I didn't make the comment today, but I've made so many times I forget I didn't make it today, that almost all the studies that have been done in multiple sclerosis for treatment strategies have had as their top age when entering the study, age 55. Some have gone to 60, some have gone to 65. When we actually report the DISCO MS data, hopefully in a couple of months, it'll actually be the largest treatment trial ever that I'm aware of people over the age of 55. So the reality is that we have almost no data because people have been excluded from studies. Now, some of the studies I mentioned with the BTK inhibitors, they actually will go up to age 65, and they'll be specifically for patients with progressive MS. So there, in a large picture sense, the problem or the challenge that is faced by individuals when they try and do studies in older individuals is that there are so many other comorbidities, other conditions, diabetes, high blood pressure, cancer, stroke, etc., that unfortunately play a role as people age, that it's very challenging to organize and do a large study where there will not be a lot of confounding issues. So that's part of the problem. And I think part of the problem is that the presently available medicines have clearly shown benefit that's greater in younger people. And the pharmaceutical companies, they don't like to take risk. They want to sort of put their money on something they think is more likely to be approvable. And so they sort of follow the program as they've seen it happen before.
Okay. There's another question on the same card, a question about Michelle Harrison's aquatherapy program and will be restarted in person. As I understand, the goal is definitely to get her back into the pool and have in-person classes, but COVID continues to confound that. So right now she's supporting twice a week exercise programs using a virtual clinic. So if you go to the Rockman MS Center's website, which is mscenter.org, there's more information on the exercise programs there, and you can sign up for them. I would strongly recommend you do it. She's outstanding.
I talked to her just recently, and she's dying to get back in the pool with everybody. So,
Okay, and so that's the weekly. So this is for any one of you that want to pick something up. What tools are available for people with MS who are experiencing cognitive and visual issues to connect with others in the MS community?
I think one of the big ones that we've learned to use a little bit better than we did in the past was just the internet. I think Zoom, other programs have just become almost a verb now. But I think the ability to kind of connect with other people, it's been kind of crazy. But I've connected more with my family over the last year than I probably had in the past. Just setting up like intermittent, weekend chats here and there and things like that. I think a lot of the classes, like we were talking about, the MS Gym have kind of gone virtual. And so I think a lot of resources have kind of been expanded to kind of get a little bit better access.
And related to that, if you like crossword puzzles, you can find endless numbers on the internet. If you like to play bridge, you can play bridge with robots or with other people in Asia if you want to. And so electronic access to brain stimulating functions, reading a book on Kindle, whatever it may be, are phenomenal and broad.
I'll give a shout out to the Rocky Mountain MS Center because I've used their resources to entertain my kids during the day sometimes as well. But they pulled in a bunch of different activities that you can do on their COVID website. specifically. And it's, great fun for just doing different things and kind of then doing interactively with other people. There's also a lot of games that you can do interactively through Zoom. They're like things you can plug into Zoom that, it's when you're talking, you can be doing some activity that's just a little bit more than just having kind of a conversation. What did we talk about and things like that, that's made it a little bit more fun to kind of interact with other people.
And then the last plug, I think for social media groups, I think there's a lot of merit sometimes in joining these big MS-based social media groups and just meeting like-minded individuals or individuals that might be encountering same issues and seeing what else has worked for other people.
Yeah. And again, remember, all those activities increase neurological reserve and brain health, so they're good to do. Another question. I'm a caregiver. How do I navigate this? What is my role? And how do I help without being annoying? It's a very important question. I'll make a comment and then you guys make comments. So we have resources for the MS Center, a social worker in particular that's skilled in this area that might be able to help guide you. We also have a palliative care clinic that we have patients go to where they do work with couples and try to identify issues and challenges and opportunities to deal with that as well. You guys have comments?
The main comment I would make is that you just have to be supportive in a broad sense, and the person who's living with MS needs to sort of tell you when to back off, when to give more help, what things they want help with, need help with, like help with, and other things that they really want to do themselves. We're really less about disability and more about ability. We want people to go out and exercise. We want them to shovel the walk if they like to shovel the walk, but we want them to do it safely. And so it'll be a fine line that every caregiver will find with that individual. But it just requires constant communication so that you are doing it in a fashion that is best for them and best for you.
Just another comment that as a caregiver that you got to take care of yourself. When you're on the airplane and the airplane's going down, the warning they always give you, right, is put on your oxygen mask first and then help others around you. So if you're not doing well, you can't help others. And so kind of taking the time to kind of just help yourself out, to be available to help other people.
And I would say this is one place that we've, I think, failed a lot badly in the United States. In the UK, they actually have respite care for caregivers. And this is especially true for individuals who have significant disability. And many of them stay home. They stay home and they would not go to a nursing home, for example. That is a major job for the family members. And they need some help. They need a vacation. They need a break sometimes. And respite care is much more advanced there than it is here. So I think we have a long way to go from a societal point of view in that regard.
Okay. So we have a question here. I'm 74 years old. I've had MS for 26 years. Had a cognitive evaluation 6 years ago. It was fine, but I'm starting to worry. When should I redo the test? And this is sort of a broader area about cognitive testing. When is it useful? When is it not? How often should it be done? Anna, you want to start out?
Yeah, I think there's significant limitations in cognitive testing. One of the things that we know is that cognitive testing is really looking at an average of what the average population looks like. So for example, if you're starting off here and you're feeling a decline to here, but maybe the average for cognitive testing is down here, it's not really going to notice any changes. I think one of the most important pieces about cognitive features or cognitive symptoms that's really important is you are experiencing what you're experiencing, and whether a test reflects that or not doesn't change the fact that you're experiencing what you're experiencing. I think most important things are really to look at what is reversible in terms of cognitive symptoms, and that's things like, are you getting enough sleep? Are you getting good quality sleep? Or are you making sure that you're going through REM cycles appropriately and not waking up every hour and a half before you're able to complete those? Are you making sure you're taking care of your mental health appropriately? Because we know uncontrolled depression, things like that, can mimic dementia in a whole phase or in a whole term that we call pseudo dementia. So really making sure that you're taking care of the things you can. And in my opinion, whether a test reflects your cognitive changes or not doesn't change what you should be doing.
But I would add that all that's true, and then also to look for comorbidities. Sometimes simple things like thyroid function, anemia, B12 deficiency could be relevant and can also contribute. So look for those other things that contribute. And unfortunately, MS does not protect us from other problems. So you can develop other conditions such as Alzheimer's or other things as you age. And of course, going into the 80s, a lot of people develop these other conditions. So one utility of the cognitive testing programs are that they can identify different patterns or different extents of disease cognitively that may suggest there's an alternative diagnosis. That's important from the point of view of the patient and their caregivers, because if you get diagnosed with Alzheimer's as a separate issue, that has a very different prognosis compared to the cognitive impairment that we see with MS. So you can use the testing in some respects for that. And there are other tests that are now available to actually make a diagnosis for other conditions such as Alzheimer's. And hopefully at some point, maybe even some therapies that are useful.
Okay. Next question has to do with fatigue. What disease-modifying therapy might help combat fatigue along with the disease? What's the best? Basically, my thought is that this hasn't been really well studied. A lot of our large phase 3 trials, it just didn't collect the right information. But in general, using the most highly effective therapy to try to shut off the inflammatory process in the brain seems to give the best chance for fatigue to gradually resolve, but it doesn't in everybody. What do you guys thought?
Yeah, and there was a recent study published by our colleagues, especially Ellen Mowry at Hopkins, where they compared 3 commonly used approaches medically, stimulants such as Adderall, Provigil, and amantadine, and in a sort of complicated crossover trial design, showed that really none of them did better than placebo. Now, other studies have shown, especially with amantadine, there's some data. It's not profound data, but data does show it does work, including recent data with an extended dosing version of it. But I think Tim's point is correct. That is, none of these are really the primary thing. The primary thing is all the things that he was talking about. All the good sleep, good eating, exercise your brain. Those are probably going to be more important. And then avoiding polypharmacy and just stimulating your brain is probably going to be as good or better than any of the approaches. That said, we have some patients that really truly do benefit from the medications. It may be a small enough subset that you don't see those as easily in relatively small clinical trials. And I'm sure that we do have people like that. So I wouldn't say we shouldn't use those medications. We do use them. But I think all the other stuff is more important at the top of the list. First thing, whenever people say, as soon as the letter F comes out of their mouth, you should say, what's your sleep? As people age, their sleep is disrupted frequently by a variety of different factors, not to mention dogs, spouses, and others. So just checking sleep is incredibly important.
And we know there's a higher rate of sleep apnea in patients with MS, so that's also an important thing to consider and look into.
Yeah. So, Dr. Alvarez, what are good medications for burning nerve pain?
For any kind of pain, I think it's important to kind of try to figure out if it's something that's reversible. Sometimes finding out that low B12 levels are part of what's driving it, and things like that. High sugars and diabetes or other things like that. So trying to prevent it, reverse it, I think becomes the first step. After that, as you start to look at pain medications, usually when I hear kind of the burning, tingling, that kind of stuff, I like to go with gabapentin or Lyrica. When you start to hear about shooting type pains, maybe you start to think about sort of carbamazepine. Sometimes there's some crossover with some of the antidepressants and Cymbalta. But again, fatigue feeds into that. So trying to figure out if you can work on some of these things by just improving sleep, because that helps you restore and kind of be able to overcome some of those symptoms. And so sometimes it's not even pain medicines that kind of helps with these things, I guess.
Okay. And I think it's also, it's also recognizing that the goal is not necessarily to get rid of all pain. Certainly, if we could do that, it would be great. But many of the medications have significant side effects, and that's not a reasonable goal now. So the reasonable goal should probably be to limit pain to the greatest degree that we can without causing undue side effects. but making someone functionally as able as possible, and also not interrupting sleep for all the reasons we've described. So the first thing is setting goals.
So Dr. Shaw, can you provide more information on Kcentra, especially as compared to Ocrevus?
Yeah, I think the biggest difference between the two, so there's some logistical differences in terms of where they're effective on that CD20 molecule that you guys hear us talk about so much. I think the biggest difference is really saying, well, which mechanism of delivery is really most compatible with where I'm at life. If that's approaching an infusion twice a year where you're spending several hours in the infusion center, then that's the best choice for you, versus if we say something like Kcentra, which is the injection once a month at home, that's just a shorter period of time and that's more approachable. I think that's the best choice.
Okay. There's a question, are saturated fats a good source for brain nutrition? Or is it recommended people with MS limit saturated fats? Actually, a normal diet in the United States has enough fats, both unsaturated and saturated, to provide pretty much all the nutritional needs of the brain. Increasing saturated fats increases the risk of raising cholesterol levels and leading to cardiovascular disease. So there's a balance there. But it also kind of depends on your own biology. So some of us are genetically predisposed to have a higher risk of atherosclerotic cardiovascular disease. Saturated fats would actually make that worse. Other families, not so much, and saturated fats is probably less of an issue for them. So this is the same as with exercise. It really has to be individualized, and diet has to be individualized to you as well. There's a question about, can you talk about supplements other than vitamin D that are helpful to MS patients? I don't really know of any that really have really much in the way of evidence. And I would point out, though, that the issue with vitamin D has to do with low blood levels of vitamin D in utero and in early life correlate with a higher risk of MS in later life. Despite a lot of small studies, we have not demonstrated that supplementing vitamin D has any particular impact on MS. Now, my colleagues disagree with me on this one, so you'll hear from them in a second. But so vitamin D is more related to the other things that it does, and it does a lot of different things related to bone health, cancer risk rates, and things like that. So if you're taking vitamin D, I would think about those other benefits. What are you guys' thoughts about vitamin D?
No, I agree with you, Tim, that there's not a lot of data that supports that taking a low vitamin D level and bringing it up has an impact. That's just a really hard kind of study to do. So we agree on that, but I think we disagree that there's, I would say there's much more data that a low vitamin D level, and these are low vitamin D levels. So these are, people in the low teens and tens on the scale that we use, compared to people who have high levels in the sort of the upper quintile, the upper 20%, that they have more disease activity in the lower levels. So they have more relapses, more scan changes, excuse me, more disability progression over time. But the hard part, which Tim definitely is correct on, is that can you show that changing that matters? And that has been difficult to nail down.
I'll mention that low levels are associated with fatigue. So, when you start talking about really low levels, I think the main thing about supplements, the way I think about them, is everything in moderation. And the big problem a little bit with vitamin D is that, unlike a lot of the other things that we get through diet, or at least most of our common diets, our diet has changed a lot in the last couple hundred years. I show of hands of how many people still eat liver on a regular basis, or the organ meats. 2, maybe 3. All right. So there you go. You guys are good. You can skip your vitamin D pills. But the vast majority of us don't eat those kinds of foods anymore. I mean, we not usually and not routinely. So that's a huge source of vitamin D. The other one is sunlight. And now, with all the warnings around wearing sunscreen and things like this. So this is, unlike most of the other supplements and vitamins that we hear about, we eat fresh foods and things like this, vitamin D is one where we're actually kind of recommending things that prevent us from getting vitamin D a lot. And so I think that we're seeing vitamin D levels that are way low. For us to see vitamin D levels below 11, which is our low level mark, is very common. When we think about that, the average vitamin D level in Aboriginal people is about 45. So that's a huge difference that we don't see with other vitamins, where because of our ability to get good, farm fresh foods, other vitamin levels have gone up as compared to being low.
Okay, what professional should be part of the care team for a patient with MS?
All of them.
This is definitely an all-in strategy. Sorry. It would include experts in nutrition, smoking cessation, physical therapy, occupational therapy, speech therapy, cognitive therapy, neuropsychologists, social workers, nurses at many different levels, advanced practice providers, and then and physicians as well, but also our related physicians, neuroradiologists, neurourologists, as well as a whole host of other folks. So it's really an all-in approach, and the good fortune that we have is that we have access to all of them where we are here.
Okay. Yeah, I think that if we want to make the biggest impact on outcomes in MS, it would be to have people help people adopt healthy, active lifestyles and a healthy diet. And that's something we have tried to put into place, but we have to try harder, I think, to get it done. How often are MRIs done in order to track MS? Yeah.
I think it's a little bit different. I think all of us feel pretty comfortable doing them annually or biannually on highly effective immunotherapy, or if you're a patient that's had a few more birthdays that is no longer on disease-modifying therapy. I think if you're in the earlier phases of the disease and on therapy that we categorize as something other than highly effective immunotherapy, I know I certainly do them a little bit more often just because we're more likely to see new MRI activity. Kind of going back to Dr. Vollmer's point that he made during the presentation, the majority of lesions that we see in the brain in MS, particularly during that inflammatory phase, tend to be silent, which is where the importance of MRI scans, especially if you're not on disease-modifying therapy early on in your disease course, becomes important.
And then there were several questions on the semaglutide that I talked about. Again, this is just one member of a family of 5 different drugs that are approved in the United States. And one question was, will it be covered by Medicaid? Don't know. It was just approved this year. It's just now coming out. Company's not yet advertising it because I understand they're having trouble making enough for the demand. So insurance companies have not yet decided what they're going to cover. Somebody asked about the cost. I think the average wholesale price for this drug is about $6,000 a year. So that's going to be an issue. That's worked out. There has to be cost-effective studies done to decide, is it worth spending $6,000 to help people drop 10, 15, 20% of their body weight? And then the other question was, how long do you stay on these medications? They're meant to be long-term medications. So semaglutide is like treating blood pressure. You put on a medication and you stay on it until the problem goes away. But in this case, as I showed you, if you go off semaglutide, you're using it for weight loss, which is only one of the things it's used for, then most likely your weight's going to go back up unless you change something else. So there was a question about when will people be able to volunteer for the study? Well, the study is just a gleam in my eye at this point. I'm still trying to work that one out. But I do think that we will try to get in the clinic as soon as we can. And then there's a number of questions on neurofilament light levels and how they might be used to help decide whether to continue therapy or stop therapy or monitor effectiveness of therapy. Any thoughts?
I think Dr. Corbett brought up a lot of issues around having to think about, we know that the levels go up as you get older, they go down as you get bigger. And there's a lot of attempts right now to try and normalize that out. There's some apps that are being developed that I think will be crucial for that. So I think it depends on what the question is that you're trying to answer, because a lot of times right now it's being used to try and answer a lot of different kinds of questions. The way I think about monitoring it would be to kind of be able to say, this is where I'm at. Does it go up or down? Did I get to a point? I think the issue right now is really hard to kind of know what's normal. And I think that's the problem with trying to look at the number itself. So within you trying to kind of see what the change is. And that's not a great use of a marker. And so I think we still need to kind of get some of that normalizing data, but there's efforts at trying to do that.
And I just have we're going to run out of time, so we're just going to deal with 2 questions. One is recommendations for minimum maximum exercise for aerobic strength, range of motion, balance, and high intensity intervals. So what I'm trying to do is actually make the distinction in exercise in terms of what the goal is. When I was talking about exercise, I'm talking about maximizing brain health and overall health. But high intensity interval training is actually meant to maximize function. And that's related if you're trying to do a sport or something where you're trying to push your body to the limit of what it's going to do. And that's fine. If you want to do it, that's great. But that's not necessary to actually just maximize general health. General health is more that active, healthy lifestyle where you're doing lots of different things, using your body, maintaining muscle mass. There's another issue, and that is that if you look at bodybuilders who have maxed out strength, basically when they hit age 30, they're steadily going downhill in terms of strength, and they can't really go above that. And that's because they're at the top of their curve. They've already maximized the size of their muscles, maximized their strength. All they see is decline. But for those of us in our group, age 60, who've been sitting around desks and in clinics, our muscle mass is actually not anywhere near its maximum performance. So even though I'm 60 years of age, if I go into the gym and do some weightlifting, I will gain strength. I will gain it quickly, and I can increase my muscle mass. So that's part of living a healthy lifestyle. It's just pushing your muscles back up a bit on the curve. You don't have to max them out, but just pushing them up so they perform better will give you better mobility, strength. You'll feel better. And it all has all the secondary effects. So the exercise for health is more that active lifestyle, not so much beating your body up, because that's not necessary to maximize health. But if you want to be a mountain climber or you want to compete in sports or something, then you have to tailor that program for that particular sport. And that's a perfectly reasonable goal, but that's different than just maximizing overall health. And the last question, open to all you guys, is what do you know about nabiximols and spasticity? Go ahead, Ann.
I know I don't know how to spell it.
We're going to start up a study actually looking at that maybe in the next 5 to 6 months. So that'll be interesting, I think, certainly.
You want to explain what nabiximols are?
What?
You might want to explain what they are in the cannabinoids.
Yeah, I don't know much about the kinetics of it.
So they're just derived from marijuana. So the cannabinoids are now called nabiximols by the FDA. And they are approved in other countries for management of spasticity and pain. They're not approved in the United States. And so Anna's going to be leading a study here. So they probably work based on the data that's been published for spasticity. I think they'll probably have some role to play in the future, but we don't know for sure yet. So again, thank you all very much for coming. And thank you for your questions. We'll try to answer more of them on the website.
Have a great weekend.
Thank you guys again for coming. Thank you presenters for all of your time today. I just wanted to do a quick announcement. If you are interested in any of the resources that were mentioned during the Q&A, including our social worker, the COVID resources, information on Michelle Harrison's online exercise program, you can leave a comment on your evaluation or you can email. My email is info@mscenter.org, info@mscenter.org, and I can send out whatever you guys are interested in. If you're interested in any of those research studies that were mentioned, including studies that are not yet started, there is information in your program handout about how to get in touch with the research department. And they suggest even if you don't currently qualify for something, you can just sign up to be put on their list and they can reach out to you as new studies come about. So please be sure to do that. Thank you.